Here we have yet another case of opacified IOL which was implanted about 3 years back, and as we can see this IOL is fairly opaque and patient had significant diminution of vision because of this. So this is usually the situation of a hydrophilic IOL manufactured by a particular company, and these are the patients who are now coming back to us after 2 or 3 years of surgery, and they have this kind of situation. And these IOLs, they require explantation and along with that implantation of a new IOL. And these IOLs are made of hydrophilic material, and as you can see the haptics are fenestrated in a Rayner design, and this usually results into a situation where the periphery of the anterior and posterior capsule are fused together. Although the adhesion of these IOLs is not so remarkable and they can be easily manipulated and lifted away from the posterior capsule, however, the concern is usually regarding the fusion of the capsule in between the fenestration of the haptics. So here we will see how to explant this while keeping the bag intact and undamaged so that we can place a fresh new IOL in the same bag. So we have made an incision which is 2.8 millimeter in size using a standard keratome, and then making another incision which will help us in stabilizing the IOL and also helping in intracameral folding of this IOL. So this particular incision is made about an angle so that we have easy manipulation with both of our hands, and once the incisions have been made we can simply manipulate the IOL and try to see if there is enough freedom of movement of the IOL without stretching the bag. And usually one has to really tug the IOL and see if the haptics can be easily released. So this is a testing position where you have to have some amount of experience and also check the stretchability of the IOL and the capsule so that none of the things are damaged. If one finds that the haptics cannot be easily removed, then one has to plan to retain the haptics by cutting them at the optic haptic junction and just removing the central optic. However, here as we can see both the haptics have been easily removed from the bag without causing any damage to the capsular bag. Now it is time to enlarge the incision a little bit, and I have had comments in my previous videos where people have commented that it looks easy but it is difficult while performing. So there are a few tricks one has to keep in mind, just like when we are delivering a nucleus in SICS surgery, we keep the incision a funnel shaped incision in the sense that there is the inner border of the incision is little broader, and that helps in engaging the nucleus. Here also we have to have the inner edge of the incision which is little broad so that it can engage the optic and also allow the IOL to be folded by the converging exit point. Keeping in haptic so that one can have a proper positioning of the IOL, and then using a Kelman forceps to hold the haptic optic junction in a manner that you have the haptic aligned so that once we start twisting this optic, it is possible for the rest of the optic to be twisted by the help of a dialer. Keeping the haptic out helps in a way that you have a desirable approach for the optic haptic junction. Always replenish your anterior chamber with viscoelastic because we don't want any further damage to the endothelium. Now gradually, with help of the forceps and also the aid of a dialer, we can provide some support and proceed on to grabbing the haptic optic junction. It's very important to have a very good grip because we'll be manipulating this IOL just like twisting it and pulling it out. The IOL has a slippery surface, and that is why it is possible that we are using a non-tooth forceps, it may again slip. But the key here is again having a good grip and a support by the haptic. If it fails once, you have to recheck your incision size and you can retry and try to pull it out. Once half of the optic is out, it is definite that rest of the optic and the haptic will come out. And here we can see the IOL has come out safely. There is some amount of iris prolapse which probably got engaged with the optic of the IOL, and because there was some pearls of Elschnick's on the capsule, so they warrant a removal. So polishing this capsule with a capsule polisher, and this will provide our patient a clear visual access without the need of a YAG laser capsulotomy. And now it is time to implant an intraocular lens, and this is a hydrophobic monofocal intraocular lens which is apparently a superior choice when compared to hydrophilic IOLs. And these patients, once they have suffered in this way that the IOL went bad with time, they are always ready to invest a little more money in purchasing a better IOL. So here we can see the IOL has been implanted, and now we have to have some space and clearance of the capsule so that we can implant the IOL in the bag and also place the haptics in the bag. And this can be readily achieved because if the capsules are not properly sticking to each other, then we can always create some space and let the IOL haptics fall into the bag. And this is a choice because this provides the most accurate anatomical position for the IOL, and also it doesn't cause any further disturbance because of no interaction with any other tissue, especially the iris. So the long-term outcomes are safer. The prolapsed iris can be reposited, and once we have deposited the iris, it is time to remove the viscoelastic gel and replace it with balance of solution. And once that has been achieved, one can aim for sealing the anterior chamber by inflating it, and this being a self-sealing incision, it will close. This is the day 1 picture and showing a good clear cornea with the air bubble in the chamber. And this is the explanted IOL. As we can see, it is hazy, and this patient had very good visual gain after surgery, and he achieved 6/9 vision unaided. Thank you.